I have this great job. I really do. And, it gets me the bully pulpit. It gets me invited around the country to talk about the importance of interprofessional education, because I think it's important that interprofessional care is often what is most needed by patients and their families. I get to talk about it all the time. And people are listening more. They're listening more because our healthcare delivery system is changing, and the reimbursement for the care that all of us who provide care receive, that's changing too. There's a greater appreciation that team-based care holds out the hope for being better care in certain populations and with certain disease entities, better care that is more affordable. So I walk around and I show slides and I tout interprofessional care. But the world is full of wise people, and the wisest among them often say back to me, well, it's very nice what you say. It sounds right. Show us. Show us the data. And that's why I need to thank you, because in your projects, you are building the case for interprofessional care, or the other way is okay too. If it's not true, what I say, then we need to know that so that we could modify or discard. So here to all of you for conducting the needed research to either validate or repudiate the statements of those like me who believe in it, who advocate for it, but who need to have the goods to prove it. Appreciate it.
So with that, I would just like to introduce Heather Congdon, who is one of the co-directors of the IP Center, is on the faculty in the School of Pharmacy, and her home campus is actually at the universities at Shady Grove. And Dr. Dave Malott. Dave Malott is with the School of Medicine, and his home campus is here in Baltimore. And they've been great colleagues in terms of the work of the center. And I know they're equally excited to hear about your work in terms of the seed grants. So with that, I would invite Jill Morgan from the School of Pharmacy to come up to talk about interprofessional students partnering to achieve respect and collaboration in teams.
So the purpose of our project was really to take a look at the knowledge, attitudes, and beliefs of our students about interprofessional team care in an ambulatory care setting. I think we have a lot of data looking at this in a hospital setting, but we wanted to see what about in ambulatory care. So what we did was we recruited students from the 6 different schools on campus, and we asked them to take a pre-survey before joining us in the clinic. The students came from were nurse practitioners, pharmacy students in their 4th year, medicine students in their 3rd or 4th year, social work students, physical therapy students, dentistry students, and also law students. We asked the students to come to 3 sessions, and they would come at lunchtime. At that time, there was a session where there was discussion on an IPE topic, which I'll go into a little bit more on the next slide. And then right after lunch, they would come into the clinic and they would see patients as a team. So we would divide these students up, and they would go in and see these patients as a team and then come out and present to the faculty that I had mentioned were part of our team. And as a joint group, we would decide on a plan of care and then go back in and discuss the plan of care with the family. At the end of the 3 weeks, we asked the students to again complete the post-survey. So a little bit about what was talked about in those lunch and learn sessions. In the very first week, there was talk about, tell us about your practice. What does it take to become a pharmacist? What does it take to become a nurse practitioner? What does it take to become a social worker? And what does it take to become a licensed practitioner? And then talk about the myths for each of your professions. Like, let's just put it all out there on the table and go through it. The second week, there was talk about what are the barriers to working as a team and how can we overcome these barriers. They also would spend some time talking about what was accomplished in clinic the week before and what worked and what they didn't think worked in their individual teams that they were forming. And then in the third week, a case was presented. So students were given a case, and they were asked to take the skills and their knowledge that they'd gained from the previous 2 weeks and apply it to this case and talk about how they would approach this case now with the knowledge that they had gained. So for this survey, and I should have mentioned on the last slide, we used a validated survey, and I have the reference down here on the bottom, for part of our survey. The other survey we used was not validated, and then we added some extra questions on. And so the questions, again, talked about the knowledge and beliefs of students working in an IPE setting and respect for each other, what their respect was for other professions and what their perceived respect was for themselves from other practitioners. So we gathered the help of a statistician to make sure that we did this the right way, and he put all this fancy stuff on there. We used pair t-tests and ANOVAs, and he used a very nice form of SAS in order to look at this data. And when we look at it at the end, what we found was we had about 95 students that completed the pre-survey, 81 students that completed the post-survey, and we were only able to match up 40 of the students. So we didn't do such a good job on following the instructions for those questions to help match them up. But they were matched up based on 8 different questions, and out of that match set, you can see that the majority of the students were female between the ages of 20 to 30. They were mostly Caucasian, and when we look at the individual programs down there near the bottom of the slide, you can see that the majority came from dentistry, nursing, and social work for the match set. We also asked the question, how many of you have participated in an IPE activity before? Because we thought that that could maybe bias or change our results a little bit, and we found out about half of them had participated in an IPE activity before, and we asked more information. A lot of the students have participated in IPE Day here at UMB. So this is the validated survey that looks at attitudes towards healthcare teams, and it's a total of 20 questions, and when we look at the pre and post score of all 20 questions, which is the very bottom line of this slide, you can see that there was a statistical difference between the pre and the post scores. The other questions that we've included here on the slide are just those that we found were to be statistically significant from the individual questions. So you can see things like team meetings foster communications among team members. Working on a team keeps most health professionals enthusiastic and interested in their jobs. The give and take among team members helps them make better patient care decisions. Now the rest of these next questions came from another group that we had used their survey, and here they were asking them about how much did you know about other professions in order to become that healthcare professional, that dentist, that lawyer? And so you can see here, again, there was a statistical significance on each of these questions that we asked. The knowledge about the different professional requirements, the knowledge about the scope of practice for each profession, and the level of respect also changed pre and post in just 3 weeks. Now looking a little bit at beliefs and bias, these are some of the questions that we had added on here to the survey. And again, our statistician, I do have to say this was not pre-validated, but our statistician did add this up and looked at the overall mean pre and post, and again found that this was significant statistically. But some of the things here you can see, to what extent do you envision healthcare delivery as a team activity changed throughout these 3 weeks? How aware of you are of your own biases towards other healthcare professionals? That also changed. How would you rate your ability to communicate effectively with other healthcare professionals? That changed. And how effective do you think you are in motivating others toward a common goal? They also felt that that changed in 3 weeks. Now, if we note, we do have to say limitation-wise, like I said, a majority of our participants were female. I don't know how it would change the data if we had more males included. Dental and physical therapy students generally only attended the session for the series for 1 session and not 3 sessions. So I think that that's very interesting that they still had a positive impact despite only coming 1 time. And of course, this was done at a single site. So from overall, we did see a difference between pre and post surveys that lets us say that the interprofessional education activity that we had was significantly effective. I do think that our students and our participants gained more knowledge and more respect for each other through this experience, and we did notice that there were positive attitudes regarding IPE in an ambulatory care setting. Now, some of the things that we're talking about for the future, we have added social determinants of health to our lunch and learn sessions. That came out through our discussions that is very important. I think something that we've all been talking about is how do you pay for this kind of a model out in practice, and we don't have an answer standing up here today. I can't tell you yet how to do that, but we're working on that. And then, of course, what do parents think about this model? And we do have some anecdotal responses here that we can tell you that in general, what we have been hearing from parents is that it's a very positive experience.
This project was to focus on the IPEC competencies 2 and 3 for interprofessional communication and then the roles and responsibilities. I think it's important that I just tell you a little bit about our child psychiatry unit to put it in context for what the students were trying to achieve. So we're a small unit. Our census is up to 10 at any given time. We serve ages 5 through 12. And we do about 300 to 340 admissions each year. We serve Baltimore City, so all over the state. However, most of our patients are from the urban areas. And these are children who are usually admitted for very extreme aggressive behaviors, lots of disruptive behaviors. These are the children who are getting expelled from school. We have 5-year-olds, so even getting expelled from preschool, and being brought to the emergency room, and unfortunately sometimes in handcuffs. They typically are patients, we have more males than females, lots of comorbid diagnoses, so ADHD, lots of trauma, PTSD, learning disorders, and many of them unfortunately have been removed from care due to neglect or abuse, and so there's DSS involvement. This is just a highlight. This was actually data from one of our divisional activities in which it was a survey through the health department, or BMOM's data. And so mothers of the children that are on the unit, it just shows the amount of family stress and social adversity of these young children and families. So 43% using drugs within the past year, 43% screening positive for all PTSD symptoms, over 20% for depression, 1 in 3 reporting smoking daily. So lots of different comorbidities, complexities. By the time the children arrive into our unit, they have had usually numerous unsuccessful educational experiences, outpatient care, and the families are really stressed. On our unit, we use a trauma-informed framework or program called ARC, which is Attention, Regulation, and Competency. And it highlights this relation-based model to help the parents and the children achieve their goals. So we know that children don't just live in bubbles. They can't live without adult relationships. And they really need to grow and thrive in dependable relationships. So unfortunately, many of these kids don't have that, and we try to replicate that on our inpatient unit. And with the nurturing and responsive relationships, then we know that early on their brains can be primed to have a strong foundation for learning and behavior and health. Specifically on the unit, we engage the children to set and reach their own daily goals and for emotional regulation, and we're using the therapeutic relationships with the staff to help them achieve these goals. So several years ago, about 2012, we did start a family game night. We have a crisis stabilization unit, so average length of stay is about 5 to 7 days, and frequently the parents feel like they're there, we don't see them, and then they come back and nothing really has, quote, changed. So we started the family game night to be able to enhance family engagement, have them be active in their treatment, to help provide a nice environment to educate the families about their diagnoses, treatment, really to help ease the transition and give them some skills so that the families feel empowered to be able to deal with some of the challenging behaviors of the children. It also really is a ritual and routine that's important to continue and establish, especially with our traumatized youth. So back to the actual project, the first thing was the didactic section. And being mindful of everyone's busy schedule, we kept it to about 90 minutes. The first section was talking about IPE, role clarity, teamwork. Dr. Scrandis did a section on the teamwork. She did a team steps presentation. And then we talked about some of the different skills to help partner with the families to change the children's regulation. So relational skills, specifically looking at some descriptive praise and positive praise. And then afterwards, all the students huddled and they determined their own teams that they would do when they had the standardized patient experience. So in the simulation lab, we had 4 groups, and they paired up with the various professions. And we had standardized patients. We actually had 2 children and their adult caregivers. And that was interesting. We wrote up a script, and we were really helping to describe a typical encounter on the child inpatient unit. And so we talked about, here's a kid who's aggressive with very oppositional behaviors, the parents there for family game night, and a typical situation would be that the family might be late, they might promise to bring McDonald's and they don't do that. Sometimes when the families are there, they might not be fully present. Sometimes they get upset when we ask them to put their phones away. And so we had a script detailing this, and the young children, standardized patients, I think struggled with, they're really good kids, and I think they struggled to emulate what some of the behaviors that we were asking them to do. So that was a huge challenge that we learned, because it's hard to practice these skills with the most obedient young child playing Uno in front of you. So that was something we weren't expecting and did happen. As the activity was going on, we were able to observe, and so we looked at specifically pre-planned triggers within the script, and then the targeted response and whether or not that student hit the response. So just one example was parents saying, like, why are all these people around? You know, who are all these students here? And the appropriate targeted response would be to make sure that the students introduce themselves and clearly describe the roles to themselves, to the parent, and to the child. Afterwards, so in the standardized session after that, they debriefed with Dr. Scrandis, and she used the good judgment model. The following week, we had them come back, and they did the live family game night on our unit. And total, so in the fall, we had not as many families as we had hoped. Our unit is very seasonally driven, so school's a very big stressor for our kids. So we had, our first group was in the early September. School was just getting back into session, and our census was really low. So we only had a total of, and this was 2 weeks of family game night, so it was only 4 total families. But there we had 6 nursing students, 1 med student, and 3 pharmacy students. And then in the spring, we had more families participating. There were 7 there, and 7 pharmacy students, 3 pharmacy students, 7 nursing students, and 2 medical students. So that was a challenge, not knowing how many families would be on the unit. So even if we had patients there, their family might not show up. So the evaluation piece of this, we were hoping to, after they practiced with the standardized patient, and then in the actual game night, we wanted to observe the students and use the PACT tool, which is the Performance for Communication and Teamwork tool. However, we realized that when you have, our unit's pretty small, and so to have, even with the few number of families that participated, when you have all the trainees, all the staff, all the families, Deb really, she's trained in this, and she was going to be the one to evaluate. She couldn't appropriately watch and get a good sense to evaluate the students. So that's something, another learning point moving forward that we need to address. The families loved this. Typically, we have family game night every week, but the difference was that with all the students, it was a much more active experience. And so in their short survey they filled out, they all found it very helpful. They liked that there were pharmacy students there and medical students there. They asked a lot of questions about their medications and diagnosis, and they felt very supported. Some of the experiences were all very positive. Some of the behaviors in the family game night, the actual game night, definitely showed some challenging behaviors, and it was great to watch the students come together and learn the skills that they had previously practiced with the standardized patients, and actually implement that. So the families felt very supported. I think it was a different feel than just being told how to handle your child or what to do. Being able to model those behaviors, they liked that, so they felt support. 80% said they would hopefully implement a weekly family game night. We were also able to provide them with a deck of Uno cards, so we're looking forward to continuing that tradition. Just an informal survey amongst all the staff and faculty involved. We liked it. We liked the energy that it brought. We felt that the parents really learned a lot more about how to handle challenging behaviors, understood the different professions that were working with them and why there were other students there. And we like it. We would like to have the staff actually participate in something similar. So kind of lessons learned and next step. So the space was a big issue. Moving forward, we would need to kind of just relocate and have different groups segregated off and have more people trained in that PAC evaluation tool. That way we could actually evaluate and given the volume and the space constraints. We need to time, we timed these sessions based on the students' calendars and when everybody had started and looking at their exam schedules, but we'd also have to make sure that that also is in best with the census. Sometimes our census is difficult to predict, however, probably trying to do it more towards the end of September or beginning of October would ensure more families on the unit. The training of the standardized patients, as I mentioned before, the one child, really, she was such a sweet young lady, but was having problems, understanding her task as far as doing some of the dysregulated behaviors. And so the second session that we did, she actually did not continue to participate, and the one young man who I think understood this a little bit better and was having fun with it, he had a sibling, and that sibling ended up being the other standardized patient, and that worked out really well.